Medicine 1, kill me if you can. So, directly going ahead with the case. 37-year-old gentleman from Gudiatam, who is a businessman, presented with fever for 7 days, which was highly with no chills and rigors. And he was with pedal edema with facial puffiness for 7 days, abdominal distension for 7 days, bilateral flank pain more on the right side for the 7 days. And for the last 3 days, he is having decreased urine output and he is complaining of passing dark colored urine. And on arrival, he was breathlessness, which was there for 2 days. So, along with the coming to past history, he's a non-case of diabetes for the last 4 years, and he has non-compliant to medications. No other comorbidities. Personal history: he is a non-smoker, occasional alcohol consumption, normal bowel habits prior to presentation, and family history. Their father is a diabetic, and there is no family history of TB. Vitals on arrival. He was respiratory rate having 33 per minute. It was temperature was 98 by Fahrenheit. BP was 110 by 70 per millimeters of mercury, and pulse rate was 140 per minute. This is a 15 by 15. There was no pallor, icterus, clubbing, sinus or lymphadenopathy. Bilateral pedal edema was present. JUP was elevated, and other system examination was. Cardiovascular system, S1, S2 heard, no LVS3. Respiratory system examination, bilateral crabs with extensive crabs were there, and right side of decreased breath sounds on infraaxillary, on infrascapular and intrascapular region, and bronchial breath sounds are present on the right side. Per abdomen was showing shifting dullness with tense, no hepatosplenomegaly. CNS examination, conscious, oriented time, place, and present, no other focal neurological deficit. So, clinical symptom analysis: patient, the 37-year-old gentleman presented with acute features suggestive of acute decompensated heart failure, precipitated by either sepsis. And on examination, there was etiology would be probably right lung cavitary pneumonia would be there, and there was an acute kidney injury because there is a history of decreased urine output in the by historically, and the passing of dark colored urine was there. So, from there, we went ahead with the investigation. Complete blood count, routine blood count showed HB of 14, total count of 11,000 with a neutrophils of 84% and platelets of 44,000, creatinine of 2.8 and a urea of 60, and electrolytes were electrolytes of sodium of 134, potassium of 4.2, and bicarb was 20. Liver function test showed total bilirubin of 1.8 and direct bilirubin of 1.47, total protein was 5.3 and albumin was 2.1. SGOT was 37 and SGPT was 31, alkaline phosphatase was 250. Urine analysis showed the RBCs of 14, hematuria was there, and WBC of 637. Bacteria was plus, and granular crust was also present. BB was switched and came out of hepatitis B, was turned to be hepatitis B positive. So this was the X-ray on presentation. Showed right mild pleural effusion with the features of infiltration is there, and along with the crabs were also present on arrival. And we are done. I went ahead with the CT since patient had a creat of 2.8. Non-contra CT was done. So CT showed a right kidney of kidney is bulky and edematous of 11.7 to 7.3, and area of hypodensity noted in the right upper and in the upper and mid pole, and there is a few air foci noted in the mid pole region, suggestive of right emphysematous use perinephric fat standing and thickened noted, and left kidney is normal in size and mid pole is noted. Lung showed bilateral cavitator lesions on more on the right middle lobe of right lung, and posterior basal segment of lower lung. Bilateral pleural effusion were also there. So he initially got admitted to ward and he was managed in NIV, and because of the worsening of breathlessness, he was shifted to ICU with in the second day itself, and cultures were taken, blood cultures, urine cultures, and the meropenem was started as the patient was suspected pyelonephritis, and our antibiogram suggested of more of everything more than 70% of resistant to penicillin, third generation penicillin. We started on meropenem directly. So these were the blood cultures, urine cultures, and sputum culture for this patient. So all has grown Klebsiella, and urine culture has grown extra E. coli. So everything was pan susceptible. So since we are on the right antibiotic, we didn't change the disease, and the patient was having the acute breathlessness. We continued on the meropenem. So On day 5 after admission, drop and bypass settings were increased and fewer spikes were persisting. And this is a day 5 X-ray, which showed increased fluid effusion in the right side, and left side also fluid effusion is developing, and he was not tolerating with the NIV. We were forced to intubate him by this time. So why was there a worsening? So in spite of being in an appropriate antibiotic and with the organism has gone pan-susceptible, why there was worsening? And since the patient has already reached day 5, so the differential at that time we thought would be either it would be an inadequate source control because there is a lung involvement and a kidney involvement. Is there a inadequate source source control is the cause of worsening, or is it a new onset hospital-acquired infection which was developed after admission, or is there a resistant organism? So by the time we were evaluating for the all the differential. So we had done a Klebsiella string test came positive, which suggested a hypervirulent Klebsiella, which explains worsening after admission. So coming to hypervirulent Klebsiella, it's actually an emerging global concern, and it is more virulent than classical Klebsiella pneumonia and capable of causing community-acquired infections, often in healthy individuals. Our patient was uncontrolled diabetes and a hepatitis B positive, which was diagnosed after coming. There is case report where hypervirulent Klebsiella has shown infections in relatively very healthy individual also. So it's recognized in the 1980s in Taiwan. At that time, the patient, a healthy individual presented with the liver abscess, also had developed an endophthalmitis, which has grown Klebsiella. From there, they have theorized about concept of hypervirulent Klebsiella. Usually, the presentation would be either a meningitis and epidural abscess, endophthalmitis, or can be there pneumonia and severe bacteremia causing liver abscess and necrotizing skin, soft tissue, or bone infection. These are the routine presentation in hypervirulent Klebsiella. So, what is the reason for the virulence of this Klebsiella? So, usually compared to the normal community-acquired Klebsiella pneumonia, they have a plasmid-mediated hypervirulence factor that is coming to the bacteria. So, especially the capsule, which provides them with the hypermucoviscous phenotype, which helps the bacteria in preventing the attack of antibiotics and helps in the survival and the production of siderophores. So siderophores are the hormones produced by bacteria, which helps in absorption of iron compound, which is essential for the bacterial growth, and the lipopolysaccharides, especially which is giving the serotype to Klebsiella. So most common virulent serotypes is K1 and K2. This most hypervirulent Klebsiella and Fimbre. All this are mainly mediated through plasmid mediated.
John, you have 1 minute to wind up.
Sure. So capsule surrounding Klebsiella pneumonia serves as a main virulence factor, and this because of this virulence factor, we have a test which is available, which is called a string test. String test confirms whether it is a viscous or a non-viscous. So after touching the agar plate with a loop, and if there is a formation of more than 5 mm, we consider to be it is considered to be string test positive. And this type of organism, almost 90%, we cannot say 100% because 10% of hypervirulent Klebsiella shows string test negative also. So we cannot say 100% positive. So 90% of the hypervirulent Klebsiella will be positive with this test. So this is the overall differences between classical pneumonia and hypervirulent pneumonia and multi-drug resistant Klebsiella pneumonia. So so acquisition will be usually classical pneumonia. You can be a nosocomial pneumonia, but hypervirulent pneumonia usually will be community-acquired pneumonia. Our patient who was actually doesn't have any exposure to hospital or any health institution, he developed pneumonia within 7 days. So our patient was is fitting in the second category. This infectious site would be pyogenic liver abscess, meningitis, endophthalmitis, severe mets, microbial mets, to a lot of soft tissues are seen in hypervirulent Klebsiella. Our patient already had a kidney as well as lung infection. and hyper non hyper with hypermucoviscosity and strictness will be positive. And the usual variants which are seen in hypervirulent Klebsiella will be K1, K2, K5, K16, K20, K454, K57, KN1. And the siderophorins, which is produced in hypervirulent Klebsiella, is enterobactin, Yersinobactin, salmonellin, and aerobactin. So,
skip to your last slide, please. We are running short. It's already 8:32, 8:35. Can you skip to your last slide? The last one,
oh,
the summary. I think we need
Sure.
to wind up. This is your last slide.
So once we got all the diagnosis, we ordered the first thing we were planning for is complete source control. So drains were placed. Right side pigtail drain was placed, and left side ICD was placed. Repeat showed CT showed evolving prostate abscess, but it was not liquefied, so we didn't do any aspiration. He was continued on meropenem for 10 days, but since of symptoms in between, we upgrade the antibiotics to ceftazidime ibiotem, but the culture has grown negative, so we stopped that antibiotic, and patient was getting better. So after 10 days of meropenem, he was changed. It was changed to levoflox. Plan to continue 6 weeks, and a plan for a interval USG screening to look for any evolving abscess. And the prostate abscess, it was not liquefied. We are planning to repeat ultrasound later to see whether it is liquefied and drainage. Currently, the patient is well and he's febrile, and he's currently in work, getting better. I plan to remove the drains as the drain output has also come down. Plan to remove the drain within 1 or 2 days.
Thank you, John. I think in the interest of time, we should skip to the next presenter, who is Nikita.